Hi everyone. In this small video, I am just going to discuss regarding a very small topic, hyperkalemia. Usually these conditions are a little bit confusing on how to remember hyperkalemia, hypokalemia and all electrolytes. So in this small video, I will be teaching you certain easy tips which can help you to remember this condition very easily. So first we should understand what is the basics of this electrolyte in our body, which is called as potassium. Please remember, potassium is an intracellular component, which means electrolytes are there, sodium is extracellular, potassium is always inside the cell. So if you have confusion how to remember the potassium is an intracellular component, just think like this. If sodium is there inside, what will happen? Sodium will cause water reabsorption. So the cell will start to swell with water. So what God has created is potassium is inside the cell and sodium is outside the cell. So around 98 percentage of the potassium is within the cell. It is an intracellular component. Only 2 percentage is present outside the cell. Okay, so it is an intracellular component. And how is this component maintained? Okay, how is that potassium is kept inside, sodium is kept outside? How is it maintained? There is a pump called a sodium potassium pump. Okay, so when the gradient is in equal amount, when the gradient is in balance, what happens is potassium remains inside the cell and sodium remains outside the cell. Now, coming on to the function of potassium, we should understand that potassium is an electrolyte which is very important for two things. One is muscle function. Number two is nerve function. So automatically you can understand if potassium is going to be in excess or if potassium is going to be in low amount, both the muscle as well as nerve function is going to be completely affected. There will be muscle cramps, muscle weakness, flaccidity, etc. Now, another important thing what we should understand in the normal physiology is the potassium is an electrolyte which is excreted by kidney. So, if there is a renal failure, automatically we understand that if there is a renal failure, potassium will not be excreted by the body, that is by the kidney. So, automatically the potassium level will start to increase in the blood. Very important to remember what is a normal value of potassium. 3.5 to 5 milliequivalents per liter. Very, very important. If the value goes less than 3.5 or if it is going to go more than 5 or 5.5, the condition is considered to be very dangerous. Okay, because potassium is an electrolyte which has to be always kept in normal limits inside the body. So that is about the basics. So what we should remember, it is an intracellular component around 98%. What is it necessary for? For the nerve function, for the muscle function. How is it excreted? By the kidney. Now coming on to remembering. So in this PowerPoint, in this video, I'll be discussing only about hyperkalemia. So what is hyperkalemia? When the serum potassium is going to be above 5 milliequivalents per liter, you call that condition as hyperkalemia. What are the causes of hyperkalemia? So we have a mnemonic to remember that. It's a very easy mnemonic to remember. The body cared too much about potassium. That is why there is hyperkalemia. So we are going to take this particular word cared. Okay, so with that, let us see what is the abbreviation of this mnemonic cared. So number one is C. C stands for cellular movement of potassium. Any condition which causes the movement of potassium from inside the cell to outside the cell. For example, a major tissue trauma, major burns. What happens is the tissues are being destroyed. So the potassium is going to move from inside the cell to outside the cell, which can cause hyperkalemia. So CARED, C-A-R-E-D, C stands for cellular movement. A stands for adrenal insufficiency. Adrenal insufficiency is a condition where there is decreased secretion of adrenocorticotropic hormone. So A stands for Addison's disease. In Addison's disease, there is hyperkalemia. Next is R. R stands for renal failure. So just now we studied that when the kidney is not functioning properly, potassium cannot be excreted from the body, ending up with increased potassium accumulation, hyperkalemia. E stands for excessive potassium intake. If a person is going to consume a high potassium rich diet, especially when there is renal impairment, it can end up with hyperkalemia. So excessive potassium intake, it can either be diet or it can be potassium supplements as medicine. The last one is D. D stands for drugs. Okay, drugs especially, there are certain drugs called as potassium sparing drugs, like for example diuretics. We have potassium sparing diuretics. When spironolactone for example is taken, okay, what can happen is one side effect is, since the potassium is being reabsorbed in the body, there can be chances for hyperkalemia. In addition, AC inhibitors, NSAIDs have close association with hyperkalemia. So please remember the word, the body care too much for potassium. So cared. What is C standing for? Cellular movement. A. Addison's disease. R. Renal failure. E. Excessive intake. And D. Drugs. Next is clinical manifestations of hyperkalemia. So I know that the muscle is going to be affected, the nerve is going to be affected. Okay, so we have another mnemonics to remember that is called as murder. Hyperkalemia can murder. So what are the clinical manifestation? M. Muscle weakness. U. Urine output can be little or it can be anuria because of renal failure. Okay, if the patient is having renal impairment, definitely urine output is going to be affected. It is going to be decreased urinary output. R. R stands for respiratory failure because it is a muscle. Respiratory muscle weakness can happen. When there is a severe hyperkalemia, what can happen? Respiratory muscle flaccidity. The patient is unable to use the respiratory muscles for breathing. R. Respiratory failure. D. D stands for decreased cardiac contractility. See, among all the electrolytes, what we are going to study, sodium, potassium, calcium, magnesium, phosphate, among all these electrolytes, an electrolyte which has close association with cardiac function is potassium. Okay, potassium, neither it should be very low, neither it should be very high. It should be within normal. Both hyperkalemia and hypokalemia can cause cardiac problems. Okay, so hyperkalemia, what happens is the heart function is going to decrease, cardiac contractility is decreased, so automatically the blood pressure is going to decrease, there is weak pulse. Next, E. E stands for early signs of muscle twitches, muscle cramps, later weakness, flaccidity. The last one is rhythm changes. This is something very important, okay, which you should know as a student. There are ECG changes for both hypo and hyper. In hyperkalemia, always the ECG changes, it is hyper. So automatically the T wave is peaked, hyper. Okay, so there is a peak T wave. Then other than that, a P wave usually we don't see. A P wave is usually a rounded wave. But here in hyperkalemia, it is a flat P wave, widened QRS complex and prolonged PR interval. Okay, so these are the changes which happens. The most important point among the ECG changes which you should remember is peaked T wave. Okay, the peaked T wave and widened QRS and prolonged PR interval. What do you mean by that? Contractility is decreasing. What is P wave standing for? It stands for depolarization. What is QRS standing for? Repolarization. Sorry, QRS is standing for depolarization of the ventricle. Okay, the time taken for the ventricles to depolarize is QRS. So it takes time. So that is why the QRS complex is widened. And again, if you're going to see PR interval is prolonged. From atrial depolarization to ventricular depolarization, if you're going to see atrial contraction to ventricle contraction, the time taken is prolonged. So that is why we say cardiac contractility is decreased. So what are the clinical manifestations? Murder. So what do we know? M stands for muscle weakness, U stands for related to urinary output, R stands for respiratory, D stands for decreased cardiac contractility, E stands for early signs of muscle twitches or cramps, and R stands for ECG rhythm changes. Okay, what is the main thing you should remember? Peak T wave. Treatment. How to take care of a patient who is suffering from hyperkalemia. It's dangerous because cardiac contractility is getting decreased. So Monitor cardiac, respiratory, neuromuscular, renal, gastrointestinal status. All the vital organs should be monitored. Withhold any potassium supplements. Sometimes patient may be administered potassium supplements, like for example, pot chlor. Okay, there is a you give this potassium supplement. Okay, so when the potassium supplement is given, especially when a patient is on Lasix, loop diuretic, we give potassium supplement. But if the potassium supplement is going to be too high, the patient can end up with hyperkalemia. Withhold any potassium supplements. Initiate potassium restricted diet. It's very important that a patient should restrict potassium. So what are the food which are high in potassium? Foods which are high in potassium, usually all vegetables are rich in potassium. The main fruit in an Indian scenario is banana. Banana is found to be rich in potassium. Other than that, if you're going to see potatoes, oranges, tomatoes, avocados, all those foods are found to be rich in potassium. So tell the patient to restrict this potassium diet. Next is, if the patient is suffering from renal failure, severe hyperkalemia, immediately the patient is put on hemodialysis in order to remove the excess potassium. Next is, we have a binder, a potassium binder, which is called as Kxalate. Okay, it is actually, the chemical component is sodium polystyrene sulfonate. You know what is this? It can be given either as orally or it can be given by enema. What happens when we are giving Kxalate to a patient? This is a potassium binder. So what will happen? It enters into the GI tract. It will absorb all the excess potassium and it is excreted via the stool. Okay, the potassium is excreted. So that is a potassium binding agent. So the most important points which you should take from this particular slide is, the main medicine is you can give a potassium binder, that is the sodium polystyrene sulfonate or Kxalate. We can think of starting the patient on dialysis if it is going to be very severe hyperkalemia. Look for the drugs, look for the diet, try to withhold it, try to restrict it. Then another important treatment what we can give is hypertonic glucose with regular insulin. You know why we give insulin for these patients with hyperkalemia? Insulin, when it is going to take glucose into the cell, it will also take potassium into the cell. How beautiful, isn't it? So the insulin is going to take not only the glucose, it will also take potassium into the cell. Once potassium enters into the cell, automatically the blood potassium will decrease. So that is why we are going to give hypertonic glucose, say 25 or 50% dextrose with regular insulin. It's a wonderful treatment for hyperkalemia, but we'll have to monitor the renal status before we do this. Next is, administer potassium excreting diuretics if renal function is not impaired. Like for example, Lasix, thiazide diuretics, hydrochlorothiazide. These are diuretics which will excrete potassium. Okay, so if you find that the patient should be started on some diuretics, then not on potassium sparing but potassium excreting diuretics like Lasix or thiazide diuretics. These are additional points. The last two are additional points. Okay, it is not like a treatment, but if at all, if a patient with hyperkalemia is in need of, say, blood transfusion, we should remember that fresh blood should be transfused for patients with hyperkalemia. Why? Because already the stored bloods, what can happen is the blood cells can break down, and that blood, each cell, when it is breaking down, it is going to release potassium. So there will be high potassium in a stored blood. So that is why fresh blood transfusion is one option for a patient with hyperkalemia, if at all, if a patient needs blood transfusion. And if there is severe hyperkalemia, we may give the patient intravenous calcium in order to prevent myocardial excitability. Okay, so we don't want the heart to go into an excitability and arrhythmias. So maybe to control that, we may give intravenous calcium. So what is the main point we should remember as a treatment for hyperkalemia? Okay, number one is, look for drugs, look for the diet. If there are any drugs which is potassium sparing, potassium supplement, stop it. Diet rich in potassium should be stopped. okay, or it should be minimized or it should be reduced. Please monitor the cardiac status, the respiratory status, because we saw in the clinical manifestations of murder, all the vital organs are being affected. So monitor that. What treatment should be started? Very severe, think about hemodialysis. Okay, if it is moderate to severe, we can give potassium binder. Okay, sodium polystyrene sulfonate, KXLate can be given. We can think about starting the patient on insulin, okay, hypertonic glucose along with that regular insulin, because insulin will take potassium into the cell. Then administer potassium excreting diuretics, potassium losing diuretics like Lasix, thiazide diuretics like hydrochlorothiazide. In addition, if patient needs blood transfusion, remember it is fresh blood. Okay, and if in order to prevent myocardial excitability, we may give intravenous calcium. So it's such a easy topic. You just have to remember, okay, the mnemonics, okay, for the causes, CARED, CARAD. For the clinical manifestations, murder, MURDER. Treatment, remember about insulin, remember about dialysis, remember potassium binder, sodium polystyrene sulfonate. Monitor all the vital parameters. So this is a very small video. I sincerely pray and I hope that this small video on hyperkalemia will be useful, especially to all nursing students. Thanks a lot for all your great support. Thank you.